The second session is about subsequent TFR remissions. So here our regional expert is Professor Hemant Malhotra, who I know very well, a good friend of mine from Jaipur, India. Professor Malhotra is also a director of iCMLf as well as an eminent physician. He's well known all over the world and not just in the regional area. He's Director of Oncology Services in Sri Ram Cancer and Super Speciality Center and professor and departmental head of medical oncology at Mahatma Gandhi Medical College in Jaipur, India. Thank you so much, Professor Hemant Malhotra, for joining us for such an important topic. Our international expert is Professor Philippe Rousselot. Please let me know if I've not pronounced it correctly, Professor Philippe, but you're an expert from Paris in France. Philippe has been involved in CML since 1995 and is a founder member of the French CML group, which has pioneered a lot of work for TFR and other concepts. He pioneered the concept of TFR with the French CML group and established the MMR loss as a trigger point to start therapy, which has helped us a lot in our TFR attempts. This is Professor Rousselot's debut as an international expert in South Asian Regional Discussion Group meeting. And we welcome you here, and we are delighted that you could be part of our group so that we can welcome you again in future. Thank you for coming and joining us.
Okay, so thank you, ladies and gentlemen, particularly our moderator for being part of this discussion today. And it's like a huge pleasure for me to share the podium, so to say, virtual podium with the likes of Professor Jane Apperly, who I know very well. I have done a preceptorship with her in her department, and Professor Philippe, who is an acknowledged expert in the TFR. So half dose TKI and TFR we've discussed in the first part. And what I'm going to do now is, should you attempt a second TFR? So your patient has failed one TFR attempt, whether after a first generation TKI or a second generation TKI, is it justified for you to attempt a second TFR? So some little bit of background slides. This is our international expert, one of the world's leaders in the science and art of TFR. Really a pleasure to have him on board with us today. So these are the goals for every single newly diagnosed patients of CML. All of you well aware of this. And since the past decade or so, the operational cure of the patient, meaning sustained molecular remission, even after stopping the tyrosine kinase inhibitor or treatment-free remission, has become a big goal, especially for the younger patients. And why do we need to do this? Why do we need to think of stopping the TKI? Because none of the TKIs is a perfect clean TKI, meaning none of the TKIs, either the first generation or the second generation, inhibits only the BCR-ABL, which is our target. They inhibit a whole lot of other kinases, and this off-target effect, you can see the kinases which most of the TKIs, whether it be the first or the second or the third generation, which our TKIs inhibit, and this is what is produce the undesired toxicities of the agent. It has been established and published that 1/3 of the patients suffer from moderate to severe side effects because of the TKI. And as we are getting to use these for a longer period of time, 5 years, 10 years, 15 years, we are seeing some serious long-term toxicities. You're aware that with dasatinib, it is pleural effusion and pulmonary hypertension. With nilotinib, it is vascular events going up to almost 20 to 25% after a 10-year period. And with imatinib, our so-called very safe first-generation TKIs, it has been observed that a gradual decrease in GFR happens. So, and there are a lot of unknown, unreported AIs which are likely to happen as the exposure to the TKI becomes more and more. So if you diagnose a patient at age 30 years, you do not want that patient to be exposed to a TKI for 3 decades, 30 years. He'll live till age 60 or 70. 40 years of TKI, God only knows what will that do to the patient. And of course, we are aware that for the young patient, exposure during pregnancy to the TKI, exposure during lactation are big issues. So the first study again, Dr. Mahon's group in France, and I must say that this was a very courageous study to do, where the rest of the world was convinced that you have to give the TKI for life. They, in a very selected group of patients, had the courage to stop the TKI, and in about 40% of patients at 12 months, and then again at 5 years, about 40% of patients could remain in deep molecular remission without the TKI. And since then, there has been a whole bunch of studies, like a whole cottage industry of studies on TFRs from all around the world. And there have been guidelines on how to do the TFR, the ESMO guidelines, the NCCN guidelines, the ELN guidelines, and the TFR or attempt at a TFR has moved from a trial setting to mainstream clinical practice. And again, when you should be cautious, when you should not do. This was published way back in 2016 by Tim Hughes and his group from Adelaide. But please keep in mind that if you have 100 patients of CML, then ultimately only 25% or one-fourth of the patients will be candidates for a successful TFR. So the majority of the patients, 75% of the patients, will be required to take the TKI for life. Now, about 50 to 60% of patients will have a molecular relapse within the first 12 months. So now the thing which we are going to discuss today is, should a second TFR be attempted? Theoretically, it's a very attractive concept because, again, all the reasons which I told you earlier, you do not want prolonged exposure of the drug, which has a lot of off-target effects for your patient, particularly your younger patient. So I'll do illustrations on what I'm trying to say by two cases, and then we will have our expert discuss, and then I'll open the forum to discussion, to give it back to Zeba, and she can open the forum to discussion by all the participants today. So our patient is a 29-year-old homemaker who is the wife of a private school teacher, diagnosed with CML CP. Low uterus risk, started on imatinib because of a young age and because the fact that she's recently married, doesn't have children. We advised the second generation TKI, but this was refused because of economic reasons. And I think this factor is extremely important when you practice in a low middle income country. So fortunately, the imatinib was well tolerated, only grade 1 toxicities. She had a quick, complete hematological response and a quick, deep molecular response. So she had a deep molecular response, since the past 4 years. Now she's 34 years of age or 35 years of age. Constant pressure every time she comes to me with her husband. When can I get pregnant? When can I have a child? And the pressure is even more from the mother-in-law, which again, I think Professor Zeba and Professor Akhil will understand, which the mother-in-law is an extremely important factor in Indian families and in families of Pakistan and families of Bangladesh. So she was counseled for a TFR. She agreed. The imatinib was stopped. At that time, she had completed more than 5 years on imatinib. She had been in deep molecular response, BCR-able, undetectable on an international scale for more than 3 years. So unfortunately, post-stop imatinib, she had a molecular response at 5 months. The BCR-able was 1.22, which is loss of major molecular response, and which is the target for restarting the TKI. And this was done on the international scale, and this was repeated after a month should she had lost major molecular response. So now my question to my expert, Professor Philippe, is that this patient obviously needs a TKI, and we have two options for her. Either we restart imatinib, But then if you use the same drug, possibly she will have little or no chance for a second TFR, or we could start this patient on a second generation TKI, hope for a deeper response as compared to imatinib, and then think of a TFR after a few years. So, like over to Dr. Philippe. And what would you do, sir, in a patient like this?
Thank you very much for this presentation and this case. I think both options are open for this patient. In the case of imatinib, I'm not so sure we can just say that there is little or no chance for a second TFR, because most of our patients we have published for a second TFR attempt were on imatinib and were on the same TKI when they try to have the second TFR. And in fact, the results are not so bad, because the results are roughly 30% of the patients that can get a second TFR, even though being retreated with imatinib. And then we have also run a prospective clinical study, which was called the nilotinib post-STIM. So that was patients that were in failure after a STIM, the inclusion in the STIM protocol, so first TFR attempt. And then they were switched to nilotinib. And the results of the second TFR was not so increased. It was 42% for those patients. And we also get some adverse events in those patients, 23% of vascular adverse events in patients that had been treated previously with imatinib for a long while. So it's something which I think it has to be discussed to the patient. Your patient she has no risk, no vascular risk. I think she's young. She has no vascular risk identified. So both options are open, but I'm not so sure that one is better to the other. And at that stage, perhaps I want just to give the microphone to Jane, because you spoke about pregnancy. And perhaps there is something which is very important to say, that the criteria for pregnancy are not exactly the same than criteria for TFR. And perhaps Jane can make a comment on that, because I think it's a very important point.
One question to Hemant, sir. You told that the family was desperately wanting to get pregnant. So have you allowed the lady to conceive once you went to TFR, or you are planned to wait a while to see whether her TFR sustain or not? What to be the approach in
So I
that
think that's a
situation?
very pertinent question, Professor Akhil. What we had advised the patient is that let's wait for 6 months, and if you continue to remain in deep molecular remission after 6 months, then you might try for a child. You might try to get pregnant. And unfortunately, just 5 months after stopping the imatinib, the disease came back. So like, because we know that most of the patients, if they have a molecular relapse, they relapse within the first 6 months. Of course, later on also relapse keeps happening, but majority of them, 70 to 80% relapse within the first 6 months. So we kind of thought that let's wait for 6 months and then permit her to conceive. So Jane, Professor Philippe has thrown the question to you. Do you want to come in? Are you there?
Well, so I can give you some information that is hot off the press, because next Monday we will present to the British Society of Hematology a collection of 86 patients with CML who between them have managed 125 pregnancies.
Wow.
So 86 first pregnancies, and then about 30 women who've had a second, and a couple who've had a third or a fourth, and then there's a couple of sets of twins. So in total, there's 125 babies. Interestingly, they don't quite behave as TFR patients. So one of the difficulties is, of course, that normally they haven't been on the drug for an incredibly long period of time before they want to stop, a bit like your patient. So we're not looking at people who've been treated for 8 or 10 years before they want to stop. if they stop in MR4, they have about a 50% chance of losing MMR during the pregnancy. They don't come to any harm, they don't need any treatment, but they will have a molecular relapse. If they have only achieved MMR when they stop, then almost 100% of them will lose MMR, and a proportion of those will lose complete cytogenetic response. But again, they don't seem to come to any harm. So you can get them through the pregnancy and restart the TKI once they deliver, and they go straight back into remission. So I'm becoming a bit more relaxed about what we advise, because the chances are they'll have a molecular recurrence, they'll get through the pregnancy, and they'll respond again when you restart the TKI. So it's a bit like, you know, stopping for TFR. Well, you know, if they relapse, you just go back on the drug. But increasingly, we are, if you've got somebody who has a very regular menstrual cycle and has access to pregnancy tests and is pretty sensible, then if they can stop the drug immediately they have a positive pregnancy test, they're probably going to be okay. Now, the reason that people say this is because the gestational date, if I could remind you a little bit of your obstetrics, is always taken from the date of the last menstrual period, which is obviously 2 weeks before they get pregnant, before the egg gets fertilized. For the next 2 weeks, the fertilized egg is only kind of drifting down to get itself in place, and placental formation doesn't start for about 15 days, and that's when organogenesis starts. So if you've got somebody with a really regular cycle who'll do a pregnancy test a week before they're expected to have a further bleed, and stop if it's positive, they will be perfectly safe. The problem is, and I know this is difficult in low and middle income countries, because there's a lot of pressure on people to get pregnant and there's not much money around. If you have somebody who's not going to know they're pregnant until they're 15 weeks down the line, this is not going to work, and they're at risk of a congenital malformation. So you have to choose your patient to do that with. As I say,
So one related question, Jane, is TKI, any one of our TKIs, first generation, second generation, are they absolutely safe in the second and the third trimester of pregnancy?
Well, I don't know. I mean, there's sort of, again, a debate going on about this. I don't know if anybody can say any drug is completely safe. Once the organs are formed, which is predominantly done by 18 weeks at the latest, probably the drug won't do any harm. Dasatinib is the exception because it crosses the placenta, so you wouldn't use dasatinib, and we have virtually no information for asciminib or ponatinib or bosutinib. So imatinib and nilotinib certainly look like they're fine in the third trimester and probably in the second trimester. I'm a bit cautious about recommending them, because if the patient has been, as I say, if they've been in a reasonable response before they get pregnant, you'll get them through the pregnancy without having to do anything. But you work in countries where patients often present late, and they may present late in pregnancy, in which case you are in a position where you may need to have to treat them to get the counts down. And in that situation, I think you can use imatinib sort of late second and third trimester.
Can I make a point, Jane? We published our data on 56 women who were pregnant. And these were women who hid their pregnancy from us so that we wouldn't ask them to abort it. And they would tell us in the second or third trimester, and they're wearing their bias and stuff and loose clothes. So with a busy physician treating them about 100 cases a day, it was very difficult to ask everyone whether they were pregnant or not. And that was a society pressure or a threat of a divorce or not having a first child. And you know, when we told them not to take it for a while, they would just hide and take it so that they were scared of falling more. It was just a mixed bag of patients. Some would listen, some wouldn't, and they would continue. And we didn't find any abnormalities in the kids, in these patients. And we published our data in leukemia a while back. But it's so difficult for our people here who are younger, who are in their 20s and 30s, and to tell them to not get pregnant so that they can, and their husbands will leave them. And as Hemant said, the mother-in-law, whatever. And they generally continue imatinib. They'll continue it on and off, but they'll take it because they're scared of the disease coming back. It's just a mixed bag here.
So I completely sympathize with your dilemma, and I understand that dilemma, because we obviously have a very cosmopolitan group of patients in London. So although we don't see this issue to the same extent that you do, we certainly see it. So a couple of things. The only good data we have on congenital malformations with TKIs comes from that first imatinib paper. And that is because until that paper was published, we did not know they were going to cause a problem. And many of the women contained within that paper continued the TKI for a long time into the pregnancy. Once you knew that information, to talk about what's the effect of dasatinib or nilotinib or bosutinib is all affected by the fact that most reports are in people who stopped that drug the moment they knew they were pregnant. So it's very difficult to know if it had been dasatinib instead of imatinib, what you would have seen in the way of congenital malformations. But congenital malformations were clustered, very unpleasant congenital malformations. The exomphalos is very unpleasant. Incidence in the normal population is vanishingly low. There were 3 in 60. I mean, that's too many to think it's a coincidence. The problems with the kidneys, the problems with the vertebrae, they were all the same as had been seen in the animal models. So it fitted perfectly. So I think if you continue the imatinib during the period of organogenesis, the baby is at risk. Having said that, the incidence of congenital malformations was 9%. So 91% of the women got away with it. So, you'd have to see quite a lot of women taking imatinib through the period of organogenesis before you saw too many congenital abnormalities, but the risk is there. On the other hand, with the information we have now, that if you can get somebody to MMR and they can stay in MMR for a year or so, that you can take them off the drug and they'll get through the pregnancy very safely, may be helpful in reassuring them that although they can't have a baby today, they will be able to have a baby in 2 or 3 years. So that might be a helpful piece of information.
Jane, another question.
So I think, Zeba, I think we need to get back to the matter at hand. Maybe we will have a separate webinar by the iCMLf on pregnancy and managing CML, right? Ardi, make a note of that, please. Okay? All right. So my question to my expert, Professor Philippe, is that is there data and are there studies on a second attempt at TFR? If you could quickly, kind of tell us, and then we'll move on to case 2.
Yes, of course there are. If we look from the French cohort of patients, there were 70 patients. It has been updated in Cancer in 2017. 70 patients. There is no risk of a second TFR attempt. That's very important. So no progression, no transformation on those 70 patients. And they were included after a median first TFR duration around 5 months, so quite a short first TFR duration. They have been treated for a median of 30 months after restarting the TKI before the second TFR. And the overall result is 35% of patients still without therapy after the second attempt at 36 months. So that's not so bad. And I think we have to consider the second TFR attempt because the results are quite good and there is no risk for the patient based on the results we have.
Thank you very much. So we'll move on. So we come back to our patient. So after detailed counseling, her TKI was changed. She was started on nilotinib. Other than rash, she tolerated it well. She had a quick reattainment of a deep molecular response. She was in deep molecular response post second generation TKI for 3 years. She's now 37 years of age. We attempted a TFR again with the usual precautions. TFR was successful. She was in deep molecular remission 6 months post stopping nilotinib. We advised them to go ahead and try for a baby. They were successful in that attempt, and she had a successful pregnancy, a healthy girl child, and she still is in deep molecular remission. She has a lovely daughter. I keep asking them to post pictures of the family whenever they come to me, and this is one of the success stories which we see. So, Arlene, do you want me to open this to the audience now, or should we go to case two and do a? Okay, all right. This is open house now. If there are any questions or comments from any of our listeners, and I think there are about 50 of them, would have been happy if we had made a century, but still 50 hardcore CML experts from around the region is not bad at all. Any questions, comments from you guys?
One question. One question is that
Yes,
anytime
Professor Akhil.
we know that anytime we may lose TFR, right? So when we allow pregnancy, like in the deep MR, after 6 months, probably within 3 months, she is not at least going to lose the major molecular remission at least. It is the prediction. But if she get pregnant after a month, but 3 months, it is in the major molecular remission, but after 3 months, unfortunately, major molecular remission is lost. How to maintain the pregnancy in that time? Will we just switch to the old, the interferon, or we will just continue the TKI, knowing the risk in the late first trimester or in the second trimester?
So I think I agree with Professor Jain Apperly that during the period of organogenesis, the first 3 months of pregnancy, I would not give any TKI to the patient, whether first generation or second generation or third generation. And if it's absolutely essential, if the patient is losing, say, for example, hematological response, I would add a TKI again in the second trimester. And if there is no loss of hematological response, just BCR-ABL is creeping up at the molecular level. Wait for another 3 months and start the TKI in the third trimester. So that's where you have the art of medicine. No, everything is not science. Everything will never be covered by guidelines. That's where you have to use your expertise and your gut feel many times and then decide. Professor Philippe, would you like to comment on that?
That means we can
Yes,
safely
because
delay for
you
a
have to
few more
discuss
months,
with
right?
you have to discuss with your obstetric department. For example, in my department, we agree on the fact that we will not treat a pregnant woman, even if she's in a loss of hematologic response, and we will have a cutoff value for the white blood cell count to 30,000 per millimeter. So this is something that they consider as at risk of vascular complication in the pregnancy, and so they will say that the pregnancy will become at risk. So that's our decision to do that. And so we have some patients that have a delivery with 10,000 white blood cell count without any problems. And perhaps the only thing which is perhaps a little bit touchy is the platelet counts. If the platelet counts rise, that's something which is perhaps more difficult for our obstetric colleagues, and then you can refer to the recommendation for the non-CML myeloproliferative disorders that are quite well written on this respect.
Thank you, sir. So with Zeba, with your permission, can we move to the second case?
Sure. I'm waiting for you to start it.
Okay, thank you very much. So this is case number 2. Our patient this time is a 37-year-old farmer. He is doing pretty well, no comorbidities, diagnosed with Ph positive CML CP, BCR-ABL on an international scale, 88.2 at diagnosis, but this patient is high risk. UTOS is high risk. Again, started on imatinib, not a second generation TKI because of economic reasons, tolerated the treatment well, had a complete hematological response in 2 months' time. But he did not have an optimal response at 3 months, 6 months, 9 months. At 12 months, his BCR-ABL was 1.18. We did a kinase domain mutational analysis on Sanger. The patient swore to us that he was compliant, he was taking his medications. There was no mutation detected. He was switched to dasatinib, 100 milligrams once a day. He had responded well to dasatinib, major molecular response in 3 months, BCR undetectable in 6 months, tolerated the drug well, and again, for some reason or the other, was very keen on stopping the drug. So this is a question for Professor Philippe again. We have a patient who had a suboptimal response to imatinib, switched to a second generation TKI, but now is in deep molecular response for more than 3 years. Should and can a TFR attempt be tried in a patient like this who's failed the first generation TKI? Over to you, Professor Philippe.
So we have some information from the paper of the discontinuation of second generation TKIs because most of the patients were previously treated with imatinib. And there were 2 groups of patients that were optimal responders. And for those patients, the results were very nice. They have a very high chance of TFR. And the second group was patients that were considered as suboptimal or failure. So we don't have the response for suboptimal because it's a mixture of suboptimal and failures. And for those patients, the risk to lose MMR after the first discontinuation attempt is as high as 75%. So it's something which is a low probability to success. But in fact, in this study, there were no progression at all in those patients. So once again, the probability of success is very low, but we cannot say that there is a danger for the patient to go through this attempt.
Perfect. Thank you very much, sir. So, you know, all the guidelines, all the recommendations, in fact, the 2016 paper from Dr. Tim from Adelaide, they said that this patient who's failed the first generation TKI should not be offered a TFR. Similar recommendations from the ESMO. But, you know, what we did for our patient is the patient was just adamant to stop the medication and he was ready to do it without medical advice. So we counseled them in details. We stopped the dasatinib, total duration 6 years, deep molecular response for more than 3 years. He had a molecular response at molecular relapse after stop TKI at 8 months. This kinase domain analysis showed a 317L mutation, which is a mutation which is resistant to dasatinib, but sensitive to bosutinib. He was started on 500 milligrams once a day of bosutinib. He had grade 2 diarrhea, but it settled quickly, grade 1 transaminitis, which again responded to dose reduction to 400 milligrams per day. So with the bosutinib, he had a deep molecular response. It came to undetectable in 9 months' time. Now he completed bosutinib 4 years, deep molecular response for 3 years. So now the question to Professor Philippe again, suboptimal response to imatinib, TFR failed on dasatinib, has a kinase domain mutation, responded to another second generation tyrosine kinase inhibitor, been in deep molecular response for 3 years, very desperate to stop the drug. Can we try another TFR for this patient, or should we counsel the patient that for your health, you have to take the medicine for life? Professor Philippe.
Yeah, that's a very puzzling case because it's very unusual to see a mutation arising without the selection pressure. So it is without any therapy. And I think it's the first case I see to have a mutation without any selection or any therapeutic pressure on the clones. So in this situation, it is completely different to the previous one because this patient is not only a resistant patient, but it is a patient with a mutation. And that indicates that he have probably a molecular or clonal evolution of his disease. And perhaps this patient is at high risk of progression. So we have the chance to see a very nice response to bosutinib. And as you said, the patient the mutation is sensitive to bosutinib. So I will be very conservative to say that we are happy to have this response because it's not so easy to have the response in this mutation for those patients. So I will not try to do anything else than to continue bosutinib for those patients. And perhaps we can discuss to reduce a little bit the dose, but probably it is not a good patient for a second attempt.
So I think that's precisely what we did. We counseled the patient that this is not going to be a good idea, but he was just adamant on trying to stop the drug. So what we did was we did the destiny model. We reduced the dose of bosutinib to 200 milligrams. And we monitored his BCR-ABL every month for 12 months. And 10 months post reduction of the bosutinib, he is still in deep molecular remission. His BCR-ABL on an international scale is undetectable. Adequate copies of the control gene, which is ABL1 in our country. So we now intend to try for the TFR if he remains in deep molecular remission at 12 months. So I don't know whether that is the right strategy or not, but that is what the patient wants. So now I'd like to open these two cases to the house. If anybody has any questions or comments.
I have two questions. One is one question to Philippe. That is, the patient was well in deep molecular remission with dasatinib for more than almost 3 years. But when the TFR was attempted, the TFR was not only lost, but there was a resistant mutation was there. So was it a part of the course of the disease, or stopping the drug can somehow give escape to the resistant clone to a specific TKI?
So maybe Professor Philippe can address that, please.
Yes, I think we have also we already discussed that it is not a common case to see mutation arising during the TFR. What we know is that there are progression arising during the TFR, mostly in patients that have been restarted, and not only in patients that are in failure after restarting, but patients that are good responder after restarting. And those cases have been collected. It is very few patients, it's less than 10 patients we have, for example, in France. If we analyze those 10 patients, there is no characteristic yet that can be shared and that can indicate a risk profile for patient in TFR. So the risk of progression is still there. It is very low, very, very low. And we do not know if it is linked to the TFR attempt or if it is something which can occur even though in patients that are still treated and still in good response. And we all have observed this type of patient that can transform without any indication that they will transform.
Our last
So
question
Professor
from
Philippe,
Dr. Sharma. Hemant, Dr. Sharma has asked a question. He wants to know if cytogenetic studies could be done in addition to TKD mutations whenever there's a TFR failure or relapse.
So I think that is a recommendation that if the patient has a suboptimal response or the patient has a molecular response, then a cytogenetics is advised. But the patients are many times very reluctant for a bone marrow again. So I think this patient must have been offered bone marrow aspiration and karyotyping and must have refused. I don't off my head remember whether we documented he refused bone marrow aspiration. So Professor Philippe, I'd like to suggest that this particular patient, maybe he was harboring that resistant clone, and he would have lost molecular remission sooner or later, even if we had continued dasatinib. And it just, the growth of the clone, the resistant clone, accelerated once we stopped the TKI. So maybe something like that might have happened in the patient, right?
Yeah, that's completely possible. Ideally, it could have been interesting to go back to previous samples to see if if something is possible to detect, but perhaps by NGS to have perhaps higher sensitivity. But yes, it could be the case. It could be the natural emergence of a mutated clone that continue after the discontinuation.
Thank you, sir. So this is the studies which have evaluated second attempt at TFR. You can see the TAD study, the RESTIM study, and some of them have read out, are published, and there's some ongoing studies in which, in addition to restarting the TKI, the investigators have added another agent, the Rousselot pioglitazone, changed the TKI, and we are waiting for these studies. They started the third generation TKI, so we're waiting for these results to read out. But as Professor Philippe has pointed out, for the patient who's failed one TFR attempt, it is not an absolute no-no that these patients just cannot attempt a second TFR. So there is a about a 1/3 chance of a successful second TFR also, particularly if the patient has been exposed to the first generation TKI. So there are some predictors as per these studies. The most important thing that if you do attempt a second TFR, you have to have a deep molecular response for equal to or more than 2 years. There should be no mutation. There should be no disease progression. The patient has to be very, very compliant and very, very committed. And of course, very detailed molecular testing has to be done. This has to be a very careful decision, shared decision making with an informed consent. But some chances of success, about 1/3 of the patients, and this is a readout at 3 years, can successfully attempt TFR. Some of the predictors for success of the second TFR is longer exposure to the first TKI. So 8 years, 10 years, more chance of the second TFR working. And late versus early relapse for the patient who relapses within the first 3 months of the first attempt. These are, bad risk patients, and they do much worse as compared to patients who relapse after 8 months, 10 months, 15 months, 24 months. And if the patient has a stable, deep molecular response, like 1 month 0, 2 months 0, 6 months 0, 9 months 0, as compared to somebody who has a small number of ABL genes detected on the PCR. The patients who have a consistent 0 or undetectable, they do much better. And again, as for the first TFR, most relapses occur in the first 6 months. So, ladies and gentlemen, these are my last 2 concluding slides. TFR is there to stay, certainly in the first line, and also for very carefully selected patients in the second line. But you have to have a very committed patient who is absolutely on board for regular testing. For a patient who is a little doubtful or in whom you detect signals of non-compliance, he is not a good candidate for either the first TFR or the second TFR. And testing obviously has to be done at a reliable lab, but it is possible to attempt a second TFR. We still have small studies, and we don't have large randomized studies, but it is not an absolute no-no. If the patient fails the first TFR, there is still a small chance, still some hope for the committed, compliant patient to attempt a second TFR. These are some references which Arlene will mail to you. And with this, I'd like to hand over to Professor Ziba to take the discussion forward to conclude. Thank you very much.
I think we have to close the meeting, and it's been such an interesting meeting and such a knowledgeable meeting for all of us that I'm really impressed by all the discussions. Excellent discussions, excellent presentations, and with giants from England and France, it has been really a very learning experience. We hope to see you again in the next session on 21st May, where you'll have the choice of TKIs in newly diagnosed patients and how do we decide what to use. and third-line therapy. And we look forward to all of you attending this. Dr. Malhotra will be your host. I think at that time he will be the moderator. And sorry for the glitches, Arlene and Hemant and Philippe and Jane and Akil because of that. But otherwise, it was an excellent presentation and excellent discussion. Thank you, all of you.